All right, today we're putting on our detective hats. We're going to run a full clinical investigation into the four main malignancies of the small bowel. So let's get right into it and start profiling our suspects.
You know, it's really an incredible piece of our anatomy. Think about it, over 20 feet responsible for almost all our digestion and absorption. But that sheer size and complexity also means it can be a really tricky area when something goes wrong. So what are the key culprits when things take a malignant turn?
So, we're going to approach this just like a criminal investigation. We're going to build a profile for each of our four main suspects. Understanding their unique habits, their MO, if you will, is absolutely the key to telling them apart.
And here's our lineup. We've got adenocarcinoma, lymphoma, carcinoid tumor, and metastases. Let's break down each one and find those little clues that give them away.
Okay, let's kick things off with a head-to-head comparison of our first two suspects. Now, these are the most common primary tumors, but you'll see they behave in completely different ways. One is a classic obstructor, while the other is more of a subtle infiltrator.
So first up is adenocarcinoma. This is the most common primary bad guy you're going to find in the small bowel. Its signature move, its calling card, is creating this tight, ring-like thickening of the bowel wall that, you guessed it, leads to a blockage, an obstruction. Now here's where the detective work gets really interesting. These are your high-yield associations. Adenocarcinoma just loves to hang out in the proximal small bowel, usually the duodenum. And it has some known accomplices. We know that patients with celiac disease or Crohn's disease are at a much higher risk.
Our second suspect is lymphoma, and it's usually the non-Hodgkin's type. Now, unlike our predictable adenocarcinoma, lymphoma is a true master of disguise. It can look like almost anything, a subtle infiltration, a big polyp, or even a bunch of different nodules. It also shares risk factors like celiac and Crohn's, but it adds AIDS and SLE to its list of associates.
And this quote, this really gets to the heart of the key difference. The source material calls lymphoma a soft tumor. And that makes all the difference. Because it's soft and it infiltrates rather than constricting, it almost never causes an obstruction, even when the tumor's huge.
So let's put them right next to each other. Here's the bottom line. Adenocarcinoma is proximal, in the duodenum, and it obstructs. Lymphoma, it's distal, down in the ileum. And because it's soft, obstruction is super rare. See? Two totally different profiles.
Okay, on to our next suspect, the carcinoid tumor. This one is just fascinating because it's not just about the tumor itself, oh no, it's about this whole systemic cascade of effects it can unleash on the entire body.
You know, the dead giveaway for a carcinoid on imaging often isn't even the tumor itself, which can be tiny and hiding. Instead, it's this secondary reaction you see in the mesentery, this mass with calcifications and a classic spoke wheel pattern. It's basically a big scar tissue response to the tumor. Now this sequence is absolutely critical. You have to know it. First, the tumor pops up, usually in the distal ileum, but the real trouble doesn't start until it metastasizes to the liver. And why is that? Because the liver is what normally breaks down the serotonin this tumor pumps out. Once the liver is compromised, that serotonin floods the entire body, and that's when carcinoid syndrome kicks in. And what does all that systemic serotonin do? Well, it leads to this classic triad of symptoms: flushing of the skin, really bad diarrhea, and this is the most serious one, damage to the right-sided heart valves. Let's really zero in on that last point because it is so important. Just as the source says, systemic serotonin degrades the heart valves. This is a direct chemical attack on the heart, and it classically leads to tricuspid regurgitation. It's an incredibly powerful and dangerous effect from a tumor that might be no bigger than your thumbnail.
All right, let's move on to our fourth and final suspect. This one is different from the others because it's not a primary tumor of the small bowel at all. These are cancers that started somewhere else entirely and have traveled or metastasized to get here.
So, whenever you see multiple lesions peppering the small bowel, your first thought has to be metastases. And the classic perpetrator, the poster child for this, is melanoma. It often creates these multiple target lesions, and the numbers, well, they're pretty staggering.
I mean, listen to this number. It's sobering. Melanoma spreads to the small bowel in a shocking 50%. That's half of all fatal cases. But it's not alone. Cancers from the breast and lung, and also Kaposi sarcoma, can also spread to the small bowel through the bloodstream.
Okay, we've profiled all four of our suspects. We've gathered the clues, we've examined the evidence. Now it's time for the final verdict. Let's lay everything out so you can build a rock-solid differential diagnosis.
And this right here, this table is your ultimate cheat sheet. It brilliantly summarizes the whole case. For adenocarcinoma, think proximal, think obstruction. For lymphoma, think distal, think soft tumor, no obstruction. For carcinoid, remember that distal ileum, the spoke wheel mass, and the risk of that dangerous carcinoid syndrome. And for metastases, think multiple target lesions with melanoma as your prime suspect.
So we're getting pretty good at identifying these tumors once they show up. But it begs a bigger question, doesn't it? For tumors like adenocarcinoma and lymphoma, we already know the major risk factors, things like celiac and Crohn's disease. So the real question is, how do we use that knowledge to get ahead of the game with better surveillance and prevention? Now